welcome to everybody. It's fantastic to see so many people from so many parts of the world. I think the Americas are still asleep, so we're not expecting too many from there, but we've got some really great numbers of registrants, and I hope that we'll see most of you there. My name, as mentioned, is John Rosenberg, and I am coming to you from Brisbane in Australia. As is customary in many post-colonial countries, I'd like to acknowledge the First Nations peoples on whose lands many of us are meeting today, and pay my respects to their elders past, present and emerging, and acknowledge any First Nations people who are joining us this evening, on my evening, your morning, from the various places around the world. Fantastic. As I mentioned, I'm the immediate past president of Public Health Palliative Care International, and I also just want to acknowledge Professor Luke Dellians, who is the new president of PHPCI. Joanne's going to pop a slide up because we have our international conference coming up in October this year in Bern in Switzerland. Once again, it promises to be a fantastic opportunity to look at the bridges between science and people, the links between the work that we do in the communities that we are from. And I acknowledge that there are people from all walks of life in this webinar this evening. Keep on saying that. I know it's not the same for all of you, it's great to see in the registrations that we have professionals and community members, and both are here for the webinar. So please consider whether or not you would be able to attend this superb conference. Our last one, of course, was in Bruges in Belgium, and we're over in Bern in Switzerland. So if you go to the website there, you will be able to see more information about that. So I'll move then to introducing our webinar this evening, and we have three outstanding speakers who are going to present on aspects of their work and endeavours in the space of public health, palliative care, public health approaches to bereavement support. I'll introduce each of them as they come up to present. So I'll begin by introducing Professor Samar Aoun. Samar is only about 1,000 kilometres that way from me, so a fellow Australian. Samar is from the Perrin Institute. She's the research chair in palliative care there at the University of Western Australia. And she's an international leader in this area of promotion and advocacy of public health approaches to palliative care and grief and bereavement. And she's truly done some innovative work that I think many of you have heard about, and many of you will be learning about this evening. So very pleased to have you here, Samar, and I'll hand over to you to begin your presentation. Thank you.
Thank you, John, and good morning, everyone, or good evening, everybody. It's so lovely to be able to have this opportunity to share. Let me first probably try to share things and then I'm able to talk. Sorry. Here we go. All right, I think, can you all see that? Okay, great, thank you. So,
sorry, Samar, if you could put that onto presentation view.
Yes, good point, John. There we go. Now we've sorted out the IT, we can relax a bit.
There we are, thank you.
So, yeah, thanks for the introduction, and it's a great pleasure. Thank you for the invitation. And I'm really thrilled that my colleagues Orla Keegan and Alison Penny have joined us, because that makes my presentation so much shorter. They can focus on the translation aspect and I can talk about the other stuff. So that's really a great way of doing things today. So public health model for bereavement support, who can play a role and how? Many thanks to Julian Abel and Ellen Kelleher for this amazing book that they put together, and all the contributors. They've invited us to contribute a chapter, and I'd like to acknowledge my co-author, Dr. Bruce Rumbold, Not many of you probably know, but if it wasn't for Bruce, I wouldn't be in this field whatsoever. So he was very much encouraging me to do some research in this field, and I'm indebted to him. It's been amazing to be part of this public health palliative care community. So the overview of my presentation today: who needs bereavement support? Who provides bereavement support? Who is perceived to be helpful and why? Is there an application in countries other than Australia or diseases other than cancer? How did we manage through the lens of the pandemic? Did this inform the ability of services, community organizations, and informal networks to give priority to care according to need? And then again, the translation aspect of it, which is so important. So what do we know about bereavement as it's lived out in everyday life? Very little, really, until we did this research. We knew about the minority who sought support from professional services, but not about the majority who did not seek such services. So all the research was about those who have used services. Therefore, we paid less attention to the experience and resources the majority used to learn to live with their loss. So when we look at the bereavement survey that we did, the National Bereavement Survey in Australia, there were about 90% of people were looked after by family, friends, funeral provider, as we call informal, and the community, who are health professionals, but not necessarily specialists in the palliative care field. And only 10% are the ones who sought professional services. So this gave rise to the public health palliative care, to the public health model for bereavement support. And so about 60% of people, we consider them at low risk. The majority of individuals deal with their grief with support of family and friends. Moderate risk, about 30%, in need of some additional support, e.g. peer support, volunteer-led groups, and about 10% high risk of complex grief issues. And these are the ones that may need referrals to mental health professionals. So when we looked at the three risk factors, low risk in green, moderate risk in amber, and high in red, still, no matter what risk level they are, they all use family and friend. And we didn't know about this, but it was a really good, interesting finding that the funeral providers rated quite high in terms of this. More of the high risk, the red ones, figured in the professional ones, which is quite understandable. When we look at people who had enough support, there is more predominance of people of low risk to be in those who said they had enough support, while the high risk were more in the ones that said we didn't have enough support. So what is the profile of bereaved people that we are talking about? In general, of course, it is always exceptions. The low risk would be grieving for a parent. So it's more like an expected loss and less disruptive to daily routines. The moderate risk is grieving for a spouse, but they're both from an older age. So deaths are expected, but they are very, very disruptive. The high risk is grieving for a spouse, both of them are young age, or an offspring. So deaths here are not expected and therefore really, really disruptive. But again, there are exceptions to that. So we published all this. I'm sure quite a few of you have probably seen all that. When we looked at, is there a difference between those who have used palliative care services and those who did not use palliative care services? Again, the same thing. More people have used family, friends, funeral provider, GP. There's more of those who use palliative care services who were in the professional space, because if people in palliative care tend to know more about what are other professionals who can help them, so they are signposted to them. When we ask them, okay, well, is this helpful, or how helpful it is? So the blue line is really helpful, but the red line not so much. So again, family, friends, funeral provider, religious and spiritual advisor, you can see there's more of the, more people who are helpful there. And the red lines tend to creep in as we're talking more about professionals. So again, the community, was quite clear about, how things have worked for them. Now, the type of informal social support most valued as helpful, according to the social provision scale, First of all was attachment, and that is the emotional and affectionate bonds. Second came as tangible alliance, the practical assistance, and that's again what the community is offering to each other in this space. Social integration is that perceived sense of belonging. And guidance is mainly from the health professionals' advice or information. So again, this is the articles that mention that. So Orla reached out from Ireland, and they were interested in looking at this bereavement support survey. And when we looked at their results compared to the Australian results, and again, I must say that they've used a different sampling technique. It was more stratified, but still, even though the methodologies were not the same between the two countries, family friends came top. Funeral providers was more prominent in Australia, and general practitioner more prominent in Australia. So with the variations between countries, and again, the way the surveys were conducted, again, we could see that, compassionate communities with family and friends are there helping each other. When we looked at the sufficiency of support and self-reported mental well-being, again, between the two countries, the results were so similar. So those who had sufficient support, they didn't feel that their mental well-being got worse to the same extent as those who said they did not have sufficient support. And in both countries, it was about, 50% who said they were okay, but more than that who were not okay. So the similarities were, quite interesting. And we've published an article together on that. Now we looked at, because when we did the general bereavement survey, most of those who have responded had cancer, or, they were bereaved from people who had cancer. So we looked at motor neuron disease. And again, the same profile is showing family, friends, funeral provider, GPs, and then MND associations are quite prominent in the supportive networks of people with motor neuron disease and their families. When we looked at the risk factors for complicated grief, apart from, if you have anxiety, depression, poor family functioning, 3 times more likely to have complicated grief if they had insufficient support during the disease journey, and 3 times more likely if they had a shorter period of caring, because services do not kick in really quickly for motor neuron disease because it's such a fast progressive neurodegenerative disease that the stress and anxiety of caregivers is really high during that period. So when we compared on the left the general survey and on the right the MND survey, the MND survey showed more clustering in the moderate risk group, and these are people who have been bereaved on average at least 1 year. So again, these proportions shift according to how traumatic the disease is or the traumatic experience that people have had. There's a lot of publications on motor neuron disease here. Now, with the pandemic, we had a lot of conflicting opinion. What happened to grief during the pandemic period? What we have seen is even during COVID-19 pandemic, public health strategies like compassionate communities retained their value and developed new approaches when face-to-face encounters were minimal and physical means for support were limited. Somewhat paradoxically, the loss of opportunity to say farewell itself became a different source of social connection as people posted their accounts on social media and supported each other in sharing their wishes about what might have been. So we've done some research on this. And so there were community opportunities arising from the pandemic because there was such a sharp focus on death, dying, loss and grief. And so there was, people were really now talking about improving death literacy, enabling more preparedness and ability to die at home if it's in line with their wishes, and improving grief literacy, supporting community understanding, recognition of grief, and help seeking to support the bereaved. And so what we really need is to build pandemic grief resilient supportive networks, because we haven't really finished from this pandemic, or if we get any more. So many of the projections of increased complicated grief because of the pandemic may have overestimated the importance of professional support, and the question that begs itself here, who's going to fund them anyway if we had them, and correspondingly have underestimated what family, friends and neighbors can provide. And these are some of the work that we've done with the death industry. So the key learnings for both formal and informal networks, and you've all seen this, people think that grief slowly gets smaller with time, but in reality, grief stays the same size, but slowly life begins to grow bigger around it. So we have this situation and we really need to deal with it because it's not going away. So the community needs to own its central role in end-of-life and bereavement care, with formal professionals advising, supporting, and contributing as required. We need to support these everyday assets in the community who care for the bereaved and who are already involved in the everyday lives of those who are caring and recently bereaved. And as you have seen, these assets are family, friends, neighbors, work colleagues, and of course the funeral providers in this thing. So one of the survey sort of participants talked about an example of peer support, which was a really good fit for their loss. Yeah, this woman, she lost her mother this year. So we started talking, as you do when you lose your mother. And so she said to me, would you like to join our group of mothers without mothers? So we go out for lunch on the day of our mother's birthday, not the day of our mother's passing. Then I got to talk all about my mother. And then they told me all about their mothers. Well, this is a fantastic group of friends because we talk about our mother, and it's okay to sit there for the whole lunch and talk about your dead mom, and no one's going to, oh God, can we get off this dead mom subject, you know? So former professionals may focus on emotional support, not understanding that emotional support is largely in place, but what clients need is strategic support to help them negotiate their changed world, not merely to adjust their emotions. Former professionals need to remember that they are being consulted not to deal with grief as a separate event, but as one aspect of a tangible, multidimensional loss with which that bereaved person has to live. Again, one of the quotes, I think I gave the counselors a crack at me because I thought I can't be stoic all the time and maybe I could see things differently. But to me, a counselor is supposed to give you tools and ideas on how to deal with things. I never got that in the three people I saw. So in terms of formal networks, palliative care services, again, the sort of conclusions for that, should invest their effort principally in developing community capacity for bereavement care rather than seeking to develop their own specialized bereavement services. Cemeteries, crematoria, and the funeral industry from our, again, work with them have resolved to shape a more contemporary industry and to become more intentional about their social contributions as educators, facilitators, and consultants on meaningful, effective, and therapeutic rituals for bereaved Australians. Not-for-profit organizations play a key role. They can connect both professional and community resources in a way that clinicians alone or community actors alone cannot. So they have a significant role in person-centered care. And I really had a lot of work with the motor neuron disease associations, and they play a key role between the professional and the community side of things. So, but how do we prepare the community in terms of, at large, in terms of having better death and grief literacy? The training programs in network mapping and network enhancement, these should be for both professionals and community members. Training to support the use of community-led advanced care planning within the networks, built to sustain community end-of-life and bereavement care. Programs that train community members to support the end-of-life care and how to use all the public resources for the benefit of people in those phases. And regular use of media to stimulate discussions on support needs for caregiving, dying, and grieving. I was really lucky last year to have an amazing platform as the West Australian of the Year. And I think, and the media were interested in these kind of topics. So I'm hoping, I've really spread the word wide and large, particularly in Australia for this. So it's been an amazing opportunity that I made the most of it, hopefully. So with the latest article, both three of us have written, Julian Abel, Alan Callaghan, and myself, we looked at how bereavement care really needs to be reimagined. And we need to improve social models of bereavement support. In it, we discussed that there are so many ways the communities can make this visible. Of course, everybody has got, the grief festivals, the Good Grief Festival, the Dying to Know Day, bereavement cafes, death cafes, information about community sources for bereavement support that should be readily available to the community and professionals, grief and loss policies developed for workplaces, educational institutions, sporting club, local governments. So there's a lot of work happening in all these sectors. And of course, the Compassionate City Charter, which basically galvanizes this support at the community level, which we have engaged with in our small corner of the southwest of Western Australia. So with our Southwest Compassionate Communities Network, where every person, every family, every community knows what to do when someone caring, dying or grieving, we work like all the other communities around the world in terms of activating all this community work. In one of the programs that we had, the Compassionate Connectors program, that really worked well, how the networks were really enhanced. And because we had half of the families who were home alone, or half of the patients who were home alone, the compassion networks sort of got the help for them from externally facilitated networks, about 60% of the help that they got, and only 26% from the naturally occurring networks. So all this help is during the caregiving experience, and also then later on for the family carers in the bereavement stage. And we're hoping to continue this work at the national level with a new peak body that we will be launching on the 27th of March, where we hope to be working together in weaving compassion and connection across Australia as we live, die, grieve, and care for each other. So conclusions, some people commented that the pyramid is not really great, because if we put mental health services need and the high risk right at the top, people think this is the hierarchy of importance. So we sort of put it on its we looked at the funnel model, which basically shows that the largest here are the low risk, and if people are in the moderate risk and the high risk and then can be helped in their communities, they can very well go back into being in that space of low risk. Again, this is just a generalization. There are exceptions to that. And so it sort of matches nicely then with those three-tiered model that I've showed you before. So the public health model for bereavement support has challenged some of the received wisdom in the field that we heard for a long time. It's exposed the limitations of clinical services and validated community-based approaches to bereavement support. So the optimal model of care, professional services should be aware of, encourage, facilitate, and enrich community networks, collaborating with them in mutually understood ways. This has two advantages. The first is that supportive networks are open to everyone, while professional bereavement support is available only to a small percentage of those bereaved. And secondly, stretched professional services can reserve their care for those most in need. And with the community, I mean, this is at the heart of the work that people do in the community. Be willing to stand beside the gaping hole that has opened in your friend's life without flinching or turning away. Your steadiness of presence is the absolute best thing you can give. And that's meek and divine in refuge in grief. So translation into policy and practice, I don't need to say a lot in this, except the early adopters were our peak body here in Australia, Palliative Care Australia. It was in their documents. Of course, the Irish Hospice Foundation, Orla will talk more about this. The UK National Bereavement Alliance, and we've got Penny here talking about that. The Bereavement Care Task Force for European Association for Palliative Care, probably Orla will also touch on that. King's College have also followed all the time and commented on the publications coming out of this. But it was amazing to get, everywhere we heard about health practitioners, how much this has been helping them, basically. It's fantastic that it's resonated all over the world. And so really we need to now give time to give more attention to those assets in our communities who are looking after the majority of the bereaved. Informal bereavement support is the bedrock, with formal services supplementing this support. And we really need to try and get this into our policies and also translation into practice. You may think these are mountains to climb. They may be, but it isn't the mountains ahead to climb that wear you out. It's the pebble in your shoe. Thank you very much.
Thank you very much, Smar. That's terrific. Now, there've been some questions come through, and we will attend to those at our question and answer panel following the other two presentations. I've answered a couple of questions that I've been able to give easy answers to, but there are a couple here that are worth discussing, I think, in the panel. So we'll move to our next speaker, and it's a good segue talking about translating into policy and practice, because our next speaker is Orla Keegan. And Orla is the head of bereavement and education at the Irish Hospice Foundation. And you have access to her bio that's been made available to you. And Orla is indeed going to be talking about translation into policy and practice, the example of the Irish Hospice Foundation. So thanks, Orla. Over to you.
Thanks so much, John. I think, are those slides up there now? Brilliant.
Yes.
And thank you so much, Samar. Really, really great to hear all of that. And I hope that some of what we're talking about, and I'm saying we because I'm really representing teamwork. I hope that what we talk about really does put some flesh on that in terms of how we've tried to action it in Ireland. I'm just going to talk pretty fast, so because there's a lot to get through, and assuming nothing, I guess I want to say a little bit about Ireland. Oh, my slides aren't moving forward, and they were earlier. How do we manage this? I'll try it from here. Apologies. There we go. Ireland, there are 5 million people living in Ireland, and 30,000 people die every year. We've always worked on the estimate that 10 people are impacted by each death. And so bereavement is very much a feature of Irish life. We've had a look at, well, where does bereavement fit into policy and guideline in Irish structure, if you like, and mostly it fits in through palliative care, through suicide, and through pregnancy loss. And we have some really good advanced policy guidance in those areas, stretching back to 2001, this palliative care policy, which builds on the work of Colin Murray Parkes and Worden, and does look at, normal grief, risky indicators, and then people who have got symptoms who need support. So they're very much the roots of a public health approach there. In 2017, I have a wee report up here, Finite Lives, that looked at how death, dying and grief was addressed in other government structures. Like, what about our departments of education, our departments of arts and heritage, our social protection and social welfare? So some of them addressed it, some of them didn't. The report is there at the end if you're interested in that sort of thing. But really, again, we'd be looking at that as the root of a public health approach. It's more than just health policy. We need to be spreading out into a whole of government approach. In Ireland, and I was asked to look at Irish Hospice Foundation work. So really, I guess what we try to do is make sure that we have an evidence base for the direction of our development. And the public health model is that framework, that evidence that we try and translate. And all our work is really with and through other groups and partners and community. So I think just to make that point of privileging partnership and community is important. Thank you, Samar, for such a brilliant overview of, well, what do we mean by a public health approach? In Ireland, we have two frameworks, the Irish Childhood Bereavement Network Pyramid of Bereavement Care, and then the Adult Pyramid. So while I'm not going to be talking about children today, I just really want to put them out there, because another feature of public health is that people live in families and communities through their life cycle. So children are always with us somewhere. The adult bereavement care pyramid. And again, up here, this is a collaborative project. So this public health model was developed through consensus, and Amanda Roberts, my colleague at Irish Hospice Foundation, led out on this. The model is really reflecting what Samar talked about. All bereaved people have needs that will be met informally in their communities. Some people, because of risk factors, have more complex needs, and a few people will run into the really difficult mental health space. So I guess our ambition is to try and operationalize this model through the system. Surrounding the pyramid are, I suppose, acknowledgements that people's social networks and the assets and the strengths that they have will vary. Some people are more challenged than others. Circumstances will vary. That could include the circumstances around the death, but also people's, their economic context. Grief is more than just a psychological experience, and also that grief can change and shift over time. So what I'm going to try and do is bring you through each of these levels and look at some of the examples of particularly practice that are working in Ireland at the moment. So we'll start appropriately, as Samar said, we need to be looking at where most people are in their real lives, low risk, experiencing normal bereavement. So the first example I've chosen is this symbol here. It's the end of life symbol. And the aim is to make dying and death visible in the health system where it happens. So this symbol was brought in through the hospice-friendly hospital system in Ireland. And it's used when somebody is dying or somebody has died. And here it is at a reception area in a nursing home. And I chose this example because it's very personal to me. This is the door of my dad's nursing home after he died, and the symbol is there. It meant every resident, any visitors, and all of the staff knew that this had happened, and the natural compassion was promoted. Simple, but very impactful. The next example is again reiterating what Samar said: promote the conversations, make grief visible, equip people to understand what's happening to them. So we have 2 annual grief awareness campaigns, National Grief Awareness Week and a Children's Awareness Week. And probably Alison, we built that based on the UK example of Children's Bereavement Awareness Week. So I think Alison will be in concert there. These engage the media, they engage social media, and also we would have webinars and events in communities, run by communities, in libraries, in hospitals, in community settings. So again, very much trying to normalise these conversations. Samar mentioned COVID. We have to mention COVID. Through, again, a partnership with our health service executive, we ran a public health campaign at the end of 21 through to 2022, really to focus on grief has been a real characteristic of the COVID experience, helping people to understand what's happening to them, to reach out for help from their community, but also to try and get other people to reach out into them. This was a social media and a radio campaign. And really, I just wanted to pop up the numbers here that the social media impressions showed that these types of messages, which we worked up with the HSE, reached over 2.5 million people. Remembering that I said there are only 5 million people in Ireland. So I think those sort of initiatives are very important. Moving out of that sort of campaign idea, often people yearn for a one-to-one conversation, a chance to check in, what's going on for me. So our bereavement support line, also in partnership with our health services executive, really provides that space to have a one-to-one listening conversation. Because people, I put a little quote there, it's been really helpful talking to you and knowing it's just all a part of grief. Grief can be very confusing. People don't always know what's going on for them. So that opportunity to just have a conversation with a volunteer, not with a professional. It's a trained volunteer, but it's a volunteer service, is very welcomed by people. The other value of something like a support line, it provides the opportunity for signposting to other services. So we said that there'd be maybe level 2 organized services or therapeutic services. So the line can direct people towards that. Community engagement, a relatively new program at Irish Hospice Foundation is the arts program. So because there is so much happening in this area, I've really just put down the link so people could maybe explore it a little bit themselves, and the contact of my colleague Dominic there. The types of projects really work through existing art networks and looking at how can they support grief and the exploration of grief. The picture I've put in is a men's shed in the west of Ireland, and the men there are singing a song that they themselves composed with a grief theme. So again, grieving through arts and through activity, and a great reach from that programme. And the final level 1 example I'm just putting out here is looking at the workplace as a community. We hang out with our colleagues most of the time. Do we as colleagues have a recognition of how we support each other? Does the organization have just a warmth towards grief and an acknowledgement that it will be part of normal grief experience? And that's where we can be looking at local policies, for example, and engaging the unions. And then up from that, nationally, do we have appropriate legislation and support for what we know is going to happen to us all? So that was a quick tour of the majority experience, as Samar pointed out, the level 1. Level 2 examples, and we said that level 2 was when people have additional needs and maybe are moving into organized supports, which could include peer supports. So I'm going to talk about level 2 supports as being those that provide emotional or practical support. In Ireland, it's mostly through volunteer organisations, but it can be a part of a person's professional role. For example, I've said there, mental health nurses, practice nurses. There are no bereavement standards in Ireland, but yet we all need to be clear on, well, what do we mean by a quality or a good level 2 support? So again, our example here is a collaborative example led out by Amanda Roberts again. And this is all of the majority of the bereavement support organisations working in Ireland. And they provide support from miscarriage through to suicide support, the full range, if you like. The project here is looking to develop a core competence framework for those organisations. So literature review has been completed, a 2-round Delphi survey, and 5 domains of competence have been identified. These are the domains, and there are indicators of the domains under each. Too much to go through here, but I guess it's really important for us that you know this work is happening. So what sort of skills and knowledge do people need if they're providing level 2 support around bereavement, around professional and ethical practice, around cultural competence, communication skills, and self-care and reflective practice? identifying the competence is one thing. The second part of this project, granted again through government funding, is to develop an e-learning resource to help the organisations develop these competence. Help, it won't deliver the full requirement, but it will help them. And that work is well underway. Here's some images from the e-learning, which we hope will be available in June for the networks. So again, developing capacity at level 2 collaboratively is our emphasis there. And whizzing along, I just want to give you an example on level 3, 4. Again, acknowledging that some people will have needs for clinical support. So at a national level, what we've done is again work with our health service executive and say, well, where does counselling and psychotherapy get provided? It gets provided in our system through primary care. 30% of the referrals to counselling in primary care are bereavement related. And you can see there that there are the numbers relate to the community health areas. So really what we have just completed is commissioned training of all of those counsellors in primary care. So they're all working on the same knowledge base around bereavement. And importantly, that last piece there, they also have local support for each other in terms of a grief learning environment. I've hit 15 minutes. I'm nearly at the end. I'm just going to go on, if that's okay, John, to my to my last 2 slides. Because Samar mentioned research, and it's really important that we're all the time monitoring what's happening and shaping our actions relative to evidence. And so there's some service reach outs there, such Irish Childhood Bereavement Network, and how our own services were doing after COVID. But this one, I think I really like to draw attention to, again, for its policy and government implications, the financial impacts of bereavement. So that's a piece of work that happened through 2020 and 21 and was released in 2022. So again, has a lot of implications for how economic supports are distributed, but also it links very much well into grief in the workplace. The one over here, Time to Reflect, again relates to what Samar said about the COVID bereavement experience. That's been launched in Ireland next week, and it very much does reiterate that the public health model still holds, and that we need to help reinforce the informal, not just be focusing on what was predicted as the tsunami of grief. So again, as I said, that gets released next week. The very final slide I have, and again, you would think Samar and I were sitting down and planning this, is, the summary slide. I just wanted to list the different number of and types of partners, because I think that maybe people could learn from that. Well, who do we approach to work in this area? That it's not all health, as I said, it can include the others. The European dimension was the thing I wanted to talk about, and the EAPC reference group and task force, which Joanne hosts that page on EAPC, and Irene Murphy is co-chair along with myself. We published the white paper, and it's very consistent with the public health approach, and it does call for how palliative care would look at overarching bereavement policies and linking in to the community. There's a group in Europe, the Bereavement Network Europe, which has webinars. Please have a look at their website, because again, I'm talking about the full breadth of bereavement. And I thought I would also, if it's possible, put in a quick speak for the European Grief Conference in November, just about a month after the public health one. But the messages are very connected. Thank you, and I'm sorry for going over time.
Thank you, Orla. I'm sure that that will be forgiven by all the attendees. Thank you so much for such an interesting presentation, and certainly some questions coming in which we will address in the panel. So I'll turn to our third and final speaker, Alison Penny. She is the Director of the Childhood Bereavement Network in the UK. And she's also going to be talking about translation into policy and practice in the example of her the Alliance. And Alison, I'll hand over to you, and then we'll do our panel after that. Thank you.
Thank you so much for the warm welcome, John. It's a real privilege to be with you all today, and particularly sharing a virtual platform with Samar and Orla, who've been so influential on our thinking in the National Bereavement Alliance in England, and on me personally. So thank you so much for that. I'm going to talk a little around how we have been I hope embedding and using the public health approach to bereavement in some of the work of the National Bereavement Alliance. But two caveats before I start. One is that I'm talking particularly from an England perspective, but England is part of the UK, and there are some fantastic examples from the other nations within the UK. So particularly there's some very interesting work going on in Northern Ireland around support in schools. There are some amazing initiatives across Wales through the work of Compassionate Cymru, and many of you will be aware of the fantastic work that Scottish Partnership for Palliative Care and the wider Good Life, Good Death, Good Grief movement have been developing, and I was only yesterday talking about some of their public health approaches, including the Festival of People's Storytelling that happens through the To Absent Friends festival. So my focus is on England, but I would really encourage you to look at those examples from across the UK as well. The Alliance in England brings together some of the major bereavement care providers. So traditionally, probably we have had a focus on emotional support at the top of the triangle, thinking back to those models of bereavement support. But increasingly, and thanks to multiple different influences, which I'll talk about in a moment, we've had much more of a focus on the wider supports that people use and need, and also drawing on Samar and Orla's points, a kind of a wider conceptualization of what those support needs might be. So not only looking at psychological support, but also financial support, and addressing some of the other difficulties that people might face in their bereavement. So just to summarize some of those influences on our thinking and how we have been inspired to, I hope, adopt the public health model. I was amazed to realise it's now 20 years since the National Institute for Clinical Excellence published a guidance for adults with cancer, but which had a wider bearing on setting out bereavement support that could or should be available in each area. And that very clearly set out a three-component approach. So it was, even 20 years ago, we were clearly in policy terms making it clear that not everybody would need support from professionals, and particularly kind of professional counselling and psychotherapy support, but that there were different components, some of which would be volunteer-led and some of which would be spontaneous supports in the community. In 2008, that sort of model was extended to all bereavements from those specific to palliative care. And then really from the 2010s onwards, we were increasingly influenced by Samar and Bruce's work, and also the experience, particularly within palliative care, but also within other forms of bereavement support. And I think there was a real desire to balance the emerging models around prolonged grief disorder, and that focus very much on individual needs and experiences, and thinking about particularly about the social context for bereavement, which again then kind of plays into more of a public health approach. In 2015, lots of organisations within the palliative care world in England came together to publish ambitions for palliative and end-of-life care. And very importantly, Julian Abel and others worked particularly on Ambition 6, which was around each community is prepared to help. And by prepared, we mean in both senses of the word. So prepared can have the meaning of being willing and being ready to step up and support our friends and neighbours at times of loss and grief. But also it's used in the sense of being prepared, so having the information, having the confidence to do that. So that preparation has a sort of dual focus. In 2017, we tried to set out some of those principles in a guide to commissioning bereavement services in England. So this was intended for those parts of the National Health Service who are responsible for setting out, for planning and then for funding aspects of bereavement support. And again, we tried to make it very clear that this needs to be around support for community assets as well as the provision of direct services as well. And then, of course, from 2020 onwards, we've learned so much about the impact of COVID, not only on disruptions in access to formal support, but hugely disruptive in terms of informal support as well. Samar gave some examples of the ways in which we managed to use social media and virtual forms of communication to support one another in grief. But we also know how disrupted those how disrupted funerals were, and just the capacity to be together, to hug, to share a meal, just to sit quietly with one another and offer that solace. So those influences, as well as a kind of growing understanding of death as a family event, as our colleague Jane Ribbons McCarthy would say, have been really influential. So I'm going to share just 3 examples of ways in which we've tried to embed the public health approach around guidance for local statutory health bodies, around the UK Commission on Bereavement, and then really importantly, thinking about some of the public-led public health approaches as well. So that first example around guidance, we've had a really significant reorganisation of health services in England. The Health and Care Act 2 years ago established 42 new integrated care boards. And very importantly, for the first time, that set out some statutory legal duties on those health bodies to make sure that there was sufficient provision of palliative care services. And if you sort of trace that policy through, the definition of palliative care services does include bereavement support. And so we've been working to set out what that means in a local context. And the guidance that's available for integrated health boards signposts to some updated guidance that we've produced at the National Bereavement Alliance, based on those triangle models that we've seen expressed so beautifully by Samar and her team, and also in the Irish child and adult bereavement pyramids. And these are kind of our articulation of these within that guidance for local bodies. And really importantly, what we're encouraging local areas to do is, yes, make available the provision at the top of the triangle, but also make sure that there is attention paid to supporting community assets, to supporting the provision of information about grief, so that people are supported to support one another and also to understand their own experiences. So there's examples in there as well around the training that can be provided locally, around support in schools, around social prescribing, which is a model that has been used worldwide and is particularly adopted by the NHS in England, around supporting primary care, so general practitioners and other people working in primary care to be able to signpost and support people to access support within their community to support their health and well-being. The second example I wanted to give was the work of the UK Commission on Bereavement. This is an initiative that was co-led by us at the National Bereavement Alliance with our sister organisations and networks, the Childhood Bereavement Network, Cruse Bereavement Care, Independent Age, Marie Curie, the Centre for Mental Health, and then bringing in many other organisations who've been really supportive and influential in that work. So, as you would expect, we had a large-scale consultation of bereaved people. We had responses from adults and children and young people. We also had responses from bereavement support organisations, and we also engaged with over 30,000 school pupils through Votes for Schools. We had oral evidence sessions and were advised by the Lived Experience Advisory Forum. And I suppose one of the strongest articulations of the public health model is the name of the report that emerged from all of that work, which was looking at what would be the things that we need to change as a society to make sure that people have the most manageable experience possible. And of course, what we acknowledged was it's everyone's business, and that's reflected through the principles for change that we've set out. So these are the I statements that were drawn from the things that the ambitions that we wanted every bereaved person in England and across the UK to be able to say. So the principles are about being supported by family, friends and communities around me, being supported by school, college and workplace, again picking up on some of the points that Samar and Orla made, being well supported during the death, but then really critically some practical concerns as well. So around the administration that people have to do after a death, around compassionate approaches from those who are working in professions that bring them into contact with bereaved people. And by that we mean banks and insurance companies and mobile telephone companies, as much as we do the sort of traditional workforce in this space. Two really important points about having access to an affordable and meaningful funeral, and then crucially around security in the home and having the right financial support. And then the eighth principle is around accessing the right emotional support. So that's partly about the availability of support services, but it's also about people knowing how to find them. And we've been very lucky in the UK that there has been the development of really strengthened signposting and referral opportunities. And I've at the end of the presentation, there's a link to At a Loss, which is one of the main signposting directories helping people find the support that's available to them. So just going back to those first two principles, which I guess are kind of particularly relevant for today. I just wanted to say in relation to principle one, we've made some very specific recommendations around the support for some of those festivals and community events and public awareness campaigns, many of which have been running very successfully for a number of years. And there's also a recommendation in there around grief education. And we're working very closely with colleagues across the UK. In England, we're trying to influence the Department for Education to include some psychoeducation about coping with bereavement in the primary and secondary school curriculum. And we recently, during Children's Grief Awareness Week, worked with Votes for Schools. And after about an hour's lesson around supporting one another, we were really encouraged to see this proportion of children and young people feeling confident about how to support a friend if someone important to them died. So that is an example of one of the pieces of work that we're doing under those 8 principles. But together, those 8 principles really are trying to address the needs of people that can be met at each of the levels of informal to formal support. But I wanted to finish really with some public-led approaches, because I'm very conscious that I think one of the challenges that it's really helpful to grapple with in this space is, if we are promoting a public health approach to bereavement, what role do organisations have in doing that, and what role do individuals have? So I wanted to share just a few examples of individuals and groups of bereaved people who have come together to really change the face of bereavement, I think, in England. So I just wanted to share one example from COVID. This was a very beautiful example of memorialising within a community at the time of deepest lockdown. And the woman on the left, her neighbour had been bereaved during the pandemic. Nobody was able to go into to the home to support them. They were very isolated, and this neighbour organised everybody else in the street to write messages of support and love to that bereaved person, and then she put them on a tree and then took them round and put them in the front garden so that the person could see every day the support that had been was being offered, and was the promises of support when people could actually get together as well. Second example is Griefcast, which is a podcast which you will be able to download and listen to, I think, wherever you are in the world. And this has been produced by Carrie-Ad Lloyd, who is a comedian in the UK. She has interviewed many of her other comedians and other people across the UK to share examples of their experiences of grief and how they have coped. And that podcast has a huge following now, and a very important community that sits alongside it. Third example comes from the Good Grief Trust, which was established by Linda Magistris, who was herself bereaved of her partner. And one of the campaigns that organisation is running, led by bereaved people, is the Sit With Hope campaign. So in the UK, there are in many public spaces benches that are dedicated to people who have died. The Good Grief Trust, through this campaign, has produced little plaques that can be affixed to those memorial benches, or indeed any other bench, with a code that can be scanned, which then takes people to information about grief and to sources of support. And the intention is that those are where some of those very informal conversations might be happening. People might be going back to the bench to remember the person who's died, but to have that offer of support and also a sense of community is really important. And then the last example I wanted to give is this example from Hannah, Kenya and Huzaifa, who are three bereaved students who did a takeover of one of our most popular radio programmes, the BBC Radio 4 Today programme. And in the summer, they took over the programme and edited it themselves, and the focus was on support for children and young people to become the next generation of people who are hopefully more able to talk about grief and more able to support one another. And there's been an edit of the work that they did, and it's well worth a listen. So I'll leave that for you. So those were just three examples of work support for local areas, health bodies, the UK Commission on Bereavement, looking at those sort of holistic needs and how we address them and how we can support employers, workplaces, schools, communities, and then some examples of where this work is actually happening, led by the public. Thank you very much.
Thank you very much, Alison. And look, it's just been fantastic to listen to the three of you and your presentations. The questions and answers are going off like a frog in a sock, as we say in Australia. And then there are also some other questions that were posted earlier. So we've got around 20 minutes available to us for some discussion amongst the panel. And I apologise in advance to those of you who have posted questions that won't get answered today. There's more questions than we have time to answer. But what I have noticed is that there are a number of themes coming through. So I'm just going to briefly speak, and then I will put it back to our presenters to perhaps comment on, and presenters, I'll ask you to be really crisp in your answering. So just in the interests of times. So there is a real interest in this kind of, almost it's the pathologizing of grief that makes it the business of services and healthcare professionals versus the experience of grief that is shared by people in communities. And where do those boundaries, or not boundaries, where's the intersection between those? And there's one question that's come here from Yong Hao Un, excuse me if I've pronounced your name wrong. You know, do levels 3 and 4 always need to be about mental health challenges? Bereaved people can experience deeply challenging non-mental health issues, such as domestic violence, financial issues as fallouts from deaths. So the informal social networks might be sufficient, might be insufficient, etc. What's the interface there? We've had a number of questions about that particular dynamic. So I'll hand it back to the panel and invite any of you to ask to provide an answer to that question. Who'd like to go? Orla? Yeah.
Just because of the mention of level 3, 4 there, I thought I might address that. And I see Amanda has put up a link to I suppose the booklet and the description that accompanies the pyramid. But in a way, the question there is so insightful, because that's why we elaborated and set out and separated level 3 and 4, and that we put, in terms of the pyramid, to have a circle around it about your circumstances will influence what your need is. So that idea of your other life stressors, domestic violence, the real challenges people have in their life, that they will require some type of input. It's not always a psychotherapy input, but it might be above the level 2 bereavement oriented focus. So I think that's also the piece about helping other professionals to understand something about grief, like maintain their own expertise, but to understand something about grief and the territory of grieving. And I totally understand the the issue around prolonged grief disorder and really a reluctance to pathologize. And I think it really is for professionals to engage in reflective practice. Why are they doing what they're doing? Is it because they're working again through the lens of what they know best, or can they use reflective practice to help them to come out and look at social need, not just a pathological lens?
Thanks, Orla. Do either Samar or Alison want to add anything? Yeah, Alison. I could see you wanted to.
I was just thinking as well. It's so tricky, isn't it? Because as soon as we draw a triangle, there are sort of divisions or boundaries between levels on the triangle. But I think one of the things that's really stayed with me in thinking about some of this work is that actually the community assets and the provision of a warm response from existing networks, and the provision of information about what grief is like, that's potentially helpful for 100% of the population. Not only those who don't need formal support. So it's something about, even when people aren't having a formal intervention, they're spending time in their families, at school, at work, in community settings. And so, yeah, we need to be thinking about those approaches for everybody.
Thanks, Alison. Samar, did you want to add anything? Can you unmute yourself, please?
It is about a partnership between formal networks and informal networks. I mean, this is what compassionate communities are about. It's not us, like the community working separately to the health services. That's not going to give this holistic care that we are all striving for, you know, as we die, grieve, or care for the terminally ill. So we really need to bring those two sectors together to work more efficiently, to be able to, for everybody to have a better experience moving forward.
So if we consider ourselves as representing this movement and this field of public health palliative care and compassionate communities, is there something that we could be doing in the bereavement and grief space around prevention that falls within that remit, but is quite systematic in how it progresses change? Or was that question too vague? Oh no, Alison.
Just kind of a quick reflection on that. And I'm reluctant to always say we need more research in this area, but actually I think we do. I think we really do. I think this is because one of the big questions is whether if we get it right at the level of community assets, and if we, for example, I'm thinking of some of the really nice examples in the UK. So Sue Ryder, for example, have been running a campaign called Grief Kind, which is about helping people just have the words to say, or to know how to acknowledge someone else's grief. You know, really kind of little interventions that can make a really significant difference. And Crews have been running connecting communities projects in particular areas of deprivation. And so if we're thinking about how the impact that those have, we do need to be looking a bit more at whether that then has an influence on what proportion of people need support from formal services as well. And I think that's probably one of the biggest research priorities at the moment, to look at, you know, what preventative approaches could mean longer term.
Which requires a whole picture, doesn't it? It's not this little research bit here and this big research bit here, but a whole of community, whole of government effort. Samar.
I mean, community campaigns to improve death literacy and grief literacy is really the bedrock of prevention in that sense. Because if every one of us knows how to support someone who's caring, dying, grieving, can communicate that in a good way, act in a compassionate way, we certainly will be able to help those who have no one, and therefore, because of their isolation and not socially connected, they tend to possibly go to the higher level of that peak, you know, of the pyramid. So we're not going to move forward very much if the community is not death literate or grief literate. So that education campaign is a must. And of course, in Australia, we have Dying to Know Day, where basically we try our best, but it needs to be not just 1 week of the year. It needs to be continuous in all communities, basically.
And indeed, I'd add, even with education, we're not talking simply about formal programs of education, but community knowledge and growth. Orla, you had your hand up there.
Sorry, I couldn't hit the mute button. Yes, I think the prevention question is very interesting, because again, going back to Alison's point, like the research isn't like the meta-analysis. Now, this was one from 2010. Wishok couldn't show that interventions did actually prevent complicated grief from developing. But I think the other way we need to look at it is that they are all needs at each of those levels. anyway. So even if the preventive chain that we hope for hasn't yet been demonstrated, we still need to be working with people in their bereavement to help them be less at sea, to be less alone, to understand what is happening to them. That's a genuine need. And equally, because of the sort of complexities that some people are experiencing, whether it's prolonged grief disorder or not, they still require some sort of specialist service. So prevention, we really need to look at. I 100% agree with Alison about, researching this. Thank you.
Okay, so I have a question that has come up both live and also in the questions that were posted before this webinar, and it's around low resource settings, indeed from the community level right to the country level, where public health approaches to bereavement might exist in a low resource setting. What are some of the challenges that you have observed or that you see would be important to address? Samar, you look terribly worried there.
Yeah, when you say low resource, you mean like we don't have enough services to help? Because when you look around the world, the countries that have got less of services have got the community stronger in terms of delivering that care. So it's probably sometimes it doesn't do us any favor, to maybe be in developed countries where our health services they're so good, and our health systems, that the community took a step back, and really they have been engaged for decades in something that is really their core responsibility when delivering, support for those who are caring, dying, or grieving. It used to be the same decades ago everywhere. But in our developed world, our services are so good, they have professionals, and somehow we were told they're going to do a better job than the community in those domains. And that hasn't really resulted in that. So we really need to go back it just depends if you're talking about resources in that 10% of services, basically, that the service that need to look after the 10%, or across all the tiers. So I'm talking across all the 3 tiers, Yes, let's go back to the basics, to the way we used to do it and our community used to do it, because we've lost a lot. And a lot of us are dying in hospitals, not where we want to be at home. And the statistics haven't changed. 70 to 80% of us, when you will ask, and probably in any developed countries, we really want to die at home. 14 to 20% of us are able to do that. Because why? Because we don't have a community that can sustain that. There's not enough death literacy in them. There's not enough grief literacy in them. So basically we think, yeah, let's send it back to the hospital because they can look after you better than we can at home.
Thanks, Samar. It's an interesting one, isn't it, with that interplay between community and services, and I'm using those terms, in a particular way, where communities are strong, services needed less, and then vice versa. And this is an interesting space to try and thrash that question out. There are also some questions here about the community memorial events and using shared spaces for bereavement. There's a lot of interest from people about how that actually impacts collectively on the experience of grief and bereavement. Now, with just a few minutes left, would one or two of you like to say something about that? And Alison, I'm probably throwing to you here because you of course talked about that each community is prepared to help, and how public events can help with that.
Yeah, it's a great question, and I think it's partly about communities being supported to have those kind of very public moments or places. I'm thinking of some really beautiful examples from Belgium that a colleague was sharing with me quite recently, of where very, very, very simple but very lovely architectural spaces that were available for people to come together and remember those who had died. We're really grappling with some of this in the UK at the moment, in terms of how we commemorate those who died during the pandemic. So it's a very kind of live issue, I would say. I suppose the thing is, it's about there being sort of sufficient investment in those, but also sufficient variety for people to be able to respond to places and to respond to arts, for example, with their own experiences of grief as well. So it's something about not being too prescriptive, but making sure there are those opportunities for people to come together and remember together.
Thanks, Alison.
Could I
yeah,
just
Ola.
add one thing in there? Because I think there's organized collective events, and then there's maybe spontaneous opportunities. And one of the things I often think about, when Seamus Heaney died, his last text to his wife had been, don't be afraid. He wrote it in Latin. I can't remember the Latin. And that just appeared as a huge graffiti piece on a building the following week. And the same when Sinead O'Connor died, you know, images appeared and people could reflect and look. It was acknowledging this has happened. It wasn't organized. And I think we have to sort of trust people as well.
Thanks, Ola. I think that's a fabulous example of how you know, we talk about community capacity and community assets, and this is actually what I think we mean when we are talking also about death literacy and grief literacy, is that so much of our community already has a sensitivity to, an awareness of, a capacity for support in grief and loss. But for many of us in developed countries, we have been de-skilled by our success in developing services. So there's this constant tug between the two. And also, Ruth Mareka, you have made a really good comment in the chat, which is about education in communities is based on working with rather than, you know, doing to. And of course, that is the fundamental principle behind community engagement, community development approaches. Samar, you wanted to have something to say, and then I think I'm going to do a quick run of the board to see any final remarks that people want to make. Samar, will start.
Thanks, John. I mean, if we're going to reduce the taboo and the stigma of death and grief, we need to make it more visible in the community. I mean, to have reached a stage where death is so cellular, invisible, behind closed curtains, and in hospitals, the community is not seeing death anymore. Therefore, they're freaking out if you even mention the word death. So we really need to break those taboos by making it more visible to everybody. And that's the only way to basically make sure we have those public recognition of when somebody died, the memorials, the grief support, instead of just hiding them all the time. And therefore, and then we're scared of having those conversations in public. So we need to break those barriers, and the more visibility we have, the better.
Thanks, Samar. Now, I have the unenviable task of curating our time, and there are so many good questions being asked and so many insightful comments being made, and there simply isn't the time to respond to them all. However, I think what this demonstrates is that there is this collective conversation happening, and that there are forums available for conversations to go on. There's lots of requests for more information. So I'm just mindful of that. What I'd like to do is just ever so quickly ask, that's the alarm to say it's time to wind it up, ask first Orla and then Alison, just a few comments to close, and then I'll hand back to Joanne to finish up. So Orla, over to you.
Well, I guess my overall comment is thank you, and just it's lovely to feel part of an enthusiastic community, and to see so many people participating, so much chat and so much in the Q&A, and I continue to be in awe of both Samar and Alison, really value them as colleagues and look forward to the years ahead. That's a positive note from me.
Thanks, Orla. Alison, you get the final word before Joanne gets the absolutely final word.
I guess just something about how, you know, these are challenges that artists and poets and all of us in our everyday lives have faced for millennia, as well as the particular position that we are in at the moment in specific countries and through development of health services. And I suppose that I'm reflecting a bit more on the questions around resource poor countries and what's available or what could be available. And I think it's really important for us to make sure that we think about what needs people have in a particular context and how those needs can best be met. I'm really conscious Jane McCarthy's work with colleagues on the experiences of people's experience in Senegal has been really influential, just in thinking about what are the main needs and how do we address those and who is best placed to do that. So thank you. It's felt a very enriching conversation. I'm looking forward to looking back at the chat, but thank you for being a great community within which to grapple with these community issues.
Thanks, Alison. So thank you all very much.